Hi everyone, I'm Greg Sawyer from the Moffitt Cancer Center, and I'm here today in Houston at SITC. And we're at an annual meeting, but today we're having a workshop on engineering and immunotherapy. And I'm here with Drs. Tarhini and Drs. Wang, who are presenting some of their work today at this session. So Dr. Tarhini, I know you're working in melanoma. Tell us a little bit about these tertiary lymphoid structures and the clinical trial that's ongoing.
Yeah, so the project that we're going to talk about today was nested in the context of an NCI-sponsored phase 3 clinical trial that was conducted by ECOG-ACRIN, where we tested adjuvant immunotherapy in patients with high-risk melanoma. Among the biospecimens that our patients consented to use for research were tumor tissue that we used to do histologic staining, both H&E and immunohistochemical staining. Now, we conducted whole slide imaging as well as digitization of those slides, producing digital images of histology that we used for this product. In addition, we conducted RNA microarray studies, which allow us to study the gene expression profiling within these same tumors of the same patients, so we can correlate the different biomarkers. Now, with regard to tertiary lymphoid structures, or TLS, these are ectopic lymphoid organs that form in the context of chronic inflammation, including tumors and cancers. The composition can vary from loose B-cell and T-cell clusters to actually well-organized or highly organized lymphoid structures with distinct T-cell areas and B-cell zones. Now, within these TLS, sometimes we find what we call a germinal center, which appears to be a critical locus in the production of protective immunity, and anti-tumor immunity has been correlated with neoantigen burden, humoral immunity, and even long-term survival. Now, in melanoma, there's a lot of data to support the prognostic value of TLS in patients with melanoma. So these formations, they're not encapsulated. So the immune cells that form TLS are actually exposed to the antigens within the tumor microenvironment, meaning the immune response that forms in TLS is actually more potent than immune response that forms in secondary lymphoid structures. Studies in melanoma patients treated with immune checkpoint blockade showed that these patients are more likely to respond to immunotherapy than those that do not have those structures. And that's how we took this forward in the context of this study, this E1609 study with Dr. Wang.
Oh, that's amazing. So Dr. Wang, I know this is just a tremendous amount of data. How is AI, machine learning, and data science being used to try to help our patients?
That's a good question, Greg. So as Dr. Tarhini mentioned, TLS is so important. It's basically a local immune hub that signals a positive immune response. But unfortunately, there's no standardized way to find the biomarker to identify TLS. So we have been working together. I leveraging the very rich data provided by E1609 data. So based on the AI model, we're able to automatically detect the number, density, and also the features. For example, the germinal center, which is basically indicator of the immune maturity. So combined, we come up with an AI model which can predict the outcome of patient very well in our data set. So that is phenomenal results. So next, we're going to keep improving the model based on new generation AI model called foundation model. That is the next step.
Yeah. So Dr. Tarhini, I know you had mentioned earlier that these TLS structures are generally a good prognostic for patients with melanoma. How do you see this work going forward?
So we are very excited by the results so far, and we would like to take this forward to enhance the prognostic tools that we have for our patients. So we will actually integrate our findings from the TLS with patient characteristics and disease characteristics, and try to actually enhance the prognostic value of the AJCC staging and stage groups. For example, if I have a patient with a stage 2B melanoma where we treat with immunotherapy, but we know only 35% of patients should be treated, although we don't know who these patients are. The question is, if we have a patient with a stage 2B but TLS positive, meaning has an excellent prognosis, probably we should not be treating these patients. We should be saving them the toxicities and the cost of immunotherapy, and focus on those who are TLS negative, for example, right, where we know that the prognosis is poorer, and probably these are the ones that should be treated. So this is a way of taking this forward. So we will be integrating this into other markers that we have into other systems, and enhance the prognostic value, hopefully, of the AJCC staging system, where we have a plan to test and validate.
So Dr. Wang, if you could, tell us a little bit about the advantages of using AI in this approach for our patients.
Yeah, that is a good question. So I think there's three big advantages of AI models. One is really cost effective. Currently, there's no standardized biomarker, and traditional way of identifying TLS is based on like IHC staining and also more expensive spatial omics data. So now we can leverage all information from the raw H&E slides, which is most cost effective. Second is also very time effective because in a traditional way, we have to ask our pathologist collaborator to scan all the slides one by one. Now we can make it totally automatic. The third one is we can also add more features, like morphology features. We add a possibility to detect like germinal center. We did add another layer to the TLS characterization, which we can help us build a better model. So our next step will be leverage a new generation AI model, such as the foundation model, to improve the TLS detection, especially a biomarker for melanoma.
Well, doctors, thank you so much for joining us. Your work has been an exemplar, and I know everyone is really fascinated by it. So thank you so much, and congratulations on your amazing science.